Alright guys, let's get to some of the electrophysiology of a cardiomyocyte. Now if you understand the myocyte and pacemaker physiology very well, the rest of the chapter, including the electrocardiogram and the antiarrhythmic pharmacology, will come easy. Let's start with phase 0. We are talking about myocyte action potentials. So phase 0 corresponds to the opening of the fast voltage gated sodium channels, which is why I, or current, has the sodium symbol next to it in our diagram. Now the slope of this phase 0 is directly proportional to the net ionic current provided by the sodium influx. On a side note, this is how your class 1 antiarrhythmics work. They block the sodium channels here and cause a decrease in the slope of phase 0. Know how quick and sharp this slope is, straight up. Alright, next up is phase 1, right? So the depolarization caused by the influx of sodium will actually open some transient outward, or sometimes called ITO, potassium channels. This allows a quick influx of potassium, which when combined with the sudden cessation of sodium influx creates a small little dip that is phase 1. This is called ITO for transient outward current. So this quick efflux of positive potassium makes a small dip towards a less positive value. So these inactivate pretty quickly, so you won't see any more decrease in the peak after it levels out when you hit phase 2. The opening of sodium channels in phase 0 triggered the opening of calcium channels and potassium channels that are going to dominate phase 2. These take time to open, which is why there's a delay. We're talking about the L-type calcium channels in this situation, and also the slow, delayed rectifier potassium channels. So phase 2 is flat, or often described as a plateau, because look at this, we're having calcium introduced into the cell and then potassium leaving it. There's a balance of positive charge in and positive charge out. Therefore, there's a plateau in the transmembrane potential. Let's check out this image real quick. So the calcium-induced calcium release that we saw in the table in the last chart means that the calcium that's introduced to these L-type calcium channels will bind to these ranitidine receptors and increase the calcium efflux from within the sarcoplasmic reticulum out into the cytosol. This will increase available cytosolic calcium. This will increase the ability of the myofilaments to contract because they're exposed to more calcium, therefore more active myosin interactions. Alright, now back to our table. Let's go to phase 3. Phase 3 occurs when the calcium channels are closed and only the slow delayed rectifier potassium channels remain open for potassium efflux. This leads to a net overall leak of positive potassium out of the cell. So this phase 3 is the repolarization phase, overall negative change in membrane potential, causing this slope to decrease away from the positive voltage reading. We're going back towards the negative 85. So as we hit a certain negative potential, now we're going to shift to phase 4. So phase 4 is when we've restored the negative transmembrane potential, and it's actually going to activate some different potassium channels, which are called inward potassium rectifiers. These are not the same as the ones in phase 3. The potassium channels that dominate phase 4 actually allow some potassium to come back into the cell. They work alongside the sodium-potassium ATPase pump here on the membrane to help restore intracellular potassium. So what is this leak of potassium that we're talking about on the diagram? Well, now we have completely different leak channels that allow potassium to actually leave or leak out of the cell. If we lose a positive charge, the large negative intracellular proteins that are left within the cell cannot follow the potassium out. This is what creates our net negative 85 transmembrane voltage of the intracellular environment relative to the outside. So this is the foundation between the negative 70 to negative 90 millivolt resting transmembrane potential. So what about this effective refractory period that is listed on the diagram? So to understand the effective refractory period, we need to know that it depends on the state of the voltage-gated sodium channels. These channels can be in a closed, open, or inactive state. So quickly let's draw 3 different channels. So here's one channel, here's another channel, and here's another channel. The 3 different types, again, are closed, so we'll label closed 1, this will be 2, and inactive will be 3. So number 1, we have the resting or closed state, where the activation gate is closed and the inactivation gate is out of the way. Number 2, we have the activated or open state. When this activation gate swings open, the inactivation gate is still out of the way, and now sodium can rush in. Number 3, we have the inactive state, which is when the activation gate is out of the way, but the inactivation gate swings shut and blocks any more sodium influx. So at rest, the sodium channel is chilling. The activation gate should be blocking it, the transmembrane pore, and the inactivation gate is in its normal position out of the way. Here we go. When a depolarization comes along, the activation gate will open so sodium can flow into the cell. This is due to conformational change in the channel. So now we're in the activated state with the activation gate and the inactivation gate both out of the way. This way sodium can flow in. Eventually the inactivation gate will swing over and it will obstruct the channel to block the influx of sodium. So repolarization in phase 3 will return the activation gate back to its normal state and also cause the inactivation gate to return to its normal position in the resting state. So we're back in this position. Here's the money phrase. The effective refractory period reflects a period when not enough sodium channels are in this state right here. There's only a few that are in this ready to fire position, so we create only a local depolarization. There's not enough available to propagate a depolarization to adjacent cells. So this effective refractory period is different from an absolute refractory period. An absolute refractory period is when there's absolutely no sodium channels available. All of them are completely inactive. You need phase 3 for complete repolarization to return the sodium channels back to their normal state so they're ready to fire. That's why we have to get the transmembrane potential around negative 80 millivolts for these things to be ready to go. Alright, now let's move on to the pacemaker cells. So pacemaker action potential is really important. So if we examine the pacemaker action potential of cells like the SA and the AV node, you automatically see some key differences. So let's work through these differences starting with phase 4. Now phase 4 is represented here in yellow. The different slope is because the pacemaker cells are always slowly creeping towards threshold. This is a gradual depolarization, right? Some people think this is a rather funny looking depolarization because it is not steep like phase 0 of the myocytes. This is because the depolarization in phase 4 is not driven by fast sodium channels. They are inactivated because we are not near the negative 80 millivolt transmembrane potential. So all of the sodium channels are in the inactive state. So what sodium channels are responsible for this funny sodium gradual depolarization current? We're talking about these channels right here. These are hyperpolarization activated cyclic nucleotide gated channels. Huge long name, but it tells us what is responsible for the slow gradual depolarization seen in this phase. Sometimes these are called F-type for funny channels. So as the name describes, unlike most voltage gated sensitive channels, these channels are activated by a shift towards a more negative or hyperpolarized cell. So when the cell is repolarizing, not depolarizing, when the voltage drops to around negative 50 millivolts, these channels are going to open. So as the cell is going back towards normal and you hit 50, boom, these are opening. This is the gradual depolarization associated with phase 4. This name might seem rather long and necessary, but it's inconvenient because we understand how the autonomic nervous system can control the firing rate of these pacemaker cells. So this is where the cyclic nucleotide part of the name kicks in. Remember, we're talking about cyclic AMP. So as we increase cyclic AMP through beta-adrenergic activation, we are going to bind the inside of this channel and open them. So we can increase at the rate that we open these channels, and we open tons of these channels. This increases the rate of depolarization and increases the slope. This makes a lot of sense, right? Catecholamines increase the amount of available cyclic AMP to increase the frequency at which these funny channels open to allow sodium influx to create faster, more rapid depolarizations to increase the heart rate. So let's make sure we understand this with a quick image to remind ourselves. This is a diagram showing beta-adrenergic and cholinergic signaling of the cardiomyocyte. The end result is different in a cardiomyocyte and pacemaker cell, but the initial signaling cascade is the same. Every cell relies on second messenger systems to get things done. So take a catecholamine of your choice, epi or norepi. We bind the beta-adrenergic receptor, we stimulate GS, we get adenylate cyclase activity, cyclic AMP comes here and activates protein kinase A. Protein kinase A will phosphorylate phospholamban, and we also open these channels here. This leads to an increase in cyclic AMP, increase in intracellular calcium. The cyclic AMP will also bind the HCN channels that are responsible for the funny current. This increases the baseline depolarization rate to increase the patient's heart rate. Now what if your body wanted to decrease the heart rate? Well, the vagus nerve will release acetylcholine onto muscarinic receptors on the heart. This will lead to the G inhibitory protein being activated, which has a negative or inhibitory effect on adenylyl cyclase. This decreases cyclic AMP, and this leads to a decrease in the funny current because the channels do not have any cyclic AMP to bind on the intracytosolic side. So again, the funny channels are opening less frequently, and this leads to a decrease in our heart rate. So now let's return back to the diagram. The phase 0 depolarization is the next one that we need to talk about. So the funny sodium current gradually shifts the transmembrane potential towards a more positive value. Now why is this doing this? Well, eventually we're going to open the T or transient type calcium channels. This will lead to more influx of a positive ion. This allows calcium to flow into the cell and further depolarize to now open the L-type calcium channels. These are long-acting. So the upstroke of the action potential here in phase 0 is dependent on the L-type calcium channel influx. So the upstroke, L-type calcium channels. Gradual depolarization, funny sodium channels. So compare slope 0 in a myocyte and pacemaker cell. Big difference, right? The slope of phase 0 in a pacemaker cell is not as steep compared to phase 0 in a pacemaker cell because the calcium channels responsible for this phase 0 open much slower. Sodium channels are super fast compared to the long-acting L-type calcium channels. Now what about phase 3? Phase 3 is the repolarization phase. It's always dependent on potassium. You have to understand that the calcium influx will eventually open these potassium channels, and the calcium channels close.